Just got one guy, severe pancreatitis there in A&E. So that's why we're just starting a bit late. I've got more people on here than the two of you, but I'll try and speak to both of you. Is the picture okay? Can you see all right?
Yeah.
Okay. I didn't really adjust it that much, but hopefully it's okay. Let's just see. All right. So today is quite an interesting one. We're going to basically have a theme this week. Okay. Morning, Kay. How are you? All right. So we're going to analyze an ECG today. And for those of you on Zoom, I've got a few students with me here. So I'll also just be pointing out some things to them. Did you guys have a chance to see the basics of ECG? We'll go through it. Okay. And hopefully I don't get too lost. All right. All right. So this is the ECG that we're having a look at today. And the history is that we've got a 33-year-old obese man with sharp chest pain and dyspnea. Okay, so as we do every week, we first we analyze the axis, then we analyze the rhythm by using all of these, we analyze the rate, and then we analyze each zone as we're going through. So we're going to try and do that today and see what answers that we come up with. And for those of you on Zoom, you can give us some answers as well. But let's just have a look and see. So the first thing that we need to work out is the axis. All right. So I think, let me just draw it up over here. All right. So let's put a line over here. All right. So when we're looking at the axis, there's two things that we look at. We look at leads 1 and we look at lead AVF. All right. So the lead 1 and lead AVF normally sits around there. So can you guys tell me which way is lead 1 pointing, positive or negative? In other words, pointing up or pointing down? More. Which way is it pointing more towards? Down. Am I right? Okay. So when you have a negative deflection, what it means is that electricity is moving away from that particular lead. All right. So when we look at the body, lead 1 kind of sits here. All right, where my marker is. So if electricity is moving away, then what it means is that electricity is either moving there or there. All right. And we've got 4 quadrants for the axis. We've got normal, left-sided, extreme right, and right. Okay, so it's either extreme right or right. Now, if you guys are looking a bit lost now, so just go back, have a look at the ECG basics lectures. I explain this whole thing, all right? But it's a lecture on its own. Okay, all right. And then we look at lead AVF, all right? And lead AVF sits at the bottom of the body. So which way is it pointing? Mainly positive or negative? Positive. So that means electricity is moving towards it, all right? So it's here. Yeah. Oh, sorry. I'll try. No, it's no problem. All right. So this is where lead AVF would sit. All right. And lead 1. So we said lead 1 is mainly negative. So it's either one of these. Now, and lead AVF is positive. So that means it can only be here or here. The problem is that we've kind of already decided that it can't be here, right? And it can't be here, because of the way that the electricity is moving. So that leaves us with only one option. And that option is that we've got a right-sided axis, all right? So what does it mean when we have a right-sided axis? Any idea? All right, so the heart basically has a right side and a left side, okay? And electricity normally flows from the top right to the bottom left. That's normal, right? So what happens is that if it starts moving towards the left, it tells us one of two things. Either the left has become bigger, so it's drawing more electricity, or the right has become damaged, so that there's no way for that electricity to go. So it starts going to the left-hand side. And the opposite is true, like we've got a right-sided axis. So that means the right side of the heart has become large, or the left side has become damaged. That's what it's basically telling us. And when we have the last one, which is extreme right, it means that that right side has become immensely enlarged, or the damage to the left-hand side is combined with some damage to the, let's say, the inferior side as well. But that's not that common. Okay, all right. So we know what the axis is. Now let's have a look at the rhythm. So the first thing that we start with is the P waves, all right? And I know you guys haven't seen many P waves, but we'll try and have a look. Maybe the people on Zoom can give us some sort of an idea. Do these look like normal P waves to you? I know you guys may be a bit lost. So don't stress about that. But P waves are basically telling us about atrial activity, all right? So I don't know if anybody on Zoom's got anything to add, if these look normal, the morphology of them. What I can tell you is that they're quite peaked, all right? They're actually a little bit.
Yeah, it's like P pulmonale or something.
Yeah, you're getting to it. That's 100% right. Thanks, Hedy. So we're starting to get this enlarged P wave, all right? So what this tells us is, and the first half of it is normally the right atrium, and the second half is the left atrium. But in this case, we won't worry about that too much. But what we're starting to see is that we've got a peaked P wave. So in other words, that atrium is pushing quite hard, all right? And it's the right atrium, actually, in this case, that's pushing a bit hard, all right? Then we look at the PR interval. So we look at how many, what's the space between the P wave and the QRS complex. We've got 1, 2, 3, let's say 4. So that's within normal. We've got narrow QRS complexes. We've got a QRS following every P, right? And the groupings are relatively regular. There's just a bit of sinus arrhythmia, but that's nothing to worry about. So the main thing that we know is that we've got this atrium that's pushing a little bit harder than what you would expect. The rate on this patient is 1, 2, 3, 3.5. So you're looking at about 80 to 90 beats per minute, which is a little bit fast, but not exactly a tachycardia. Then we're going to look at each zone, all right? So I'd expect somebody on Zoom to give us some sort of an answer as to what's going on. So we start normally with the inferior zone. That means those parts of the heart, that are those leads that are looking at the inferior part of the heart, right? So these are the ones that are looking from the bottom. So this is also part of the ECG basics course. So I suggest you guys watch it. Right? So we've got leads 2, 3, and AVF. What are the things that look abnormal over there to you? What can you see that doesn't look right? There's a few things.
Inverted T waves.
Very good. So we've got an inverted T wave here. Anything else that you notice that we don't normally see?
Bit of ST depression.
It's like
Q wave.
Yeah, there you go. There's a Q wave over there, and we've got an inverted T. Very good, Hedy. And we've got the slight ST depression that's going on over there. So we could be looking at an ischemia. And we did say it's a 33-year-old guy. He's having dyspnea. He's having chest pain as well. All right. Okay, very good. So that's what we've got. So let's look at the septum next. All right. So V1 and V2 are those that are looking at the septum. And what do we notice over there? First, I would point out this. All right. What does that look like, guys? Hedy, are you going to answer me again? I see everybody else is on mute.
ST depression.
Okay, so that's an ST depression, that's for sure. And this little pattern over here, this M, significant.
Oh, it's
Sorry?
like a bundle branch block.
Yeah, right bundle branch block. Yeah, right bundle branch block. All right, so we've got a right bundle branch block, ST depressions with an inverted T wave, which we expect in V1 in any case. And in V2, what do we notice as well? This ST depression. Okay. So we're starting to see this pattern of ST depressions all over the place. Okay. Then we look at the anterior segment of the heart. And what do we see again in V3 and V4? We start seeing ST depression. All right. Yeah, thanks, Hedy. No, you're 100% right. Don't stress. So V3, V4, we're starting to see ST depressions. And then if we look at V5, V6, again, which are the lateral leads, we see a little bit of an ST depression there.
It's a depression.
VL, which are our high lateral leads, what do we notice? What do we see? There's a few things that are a little bit abnormal, besides depressions and elevations. And some things we don't normally see in leads 1 and AVL. And that's normally this S wave. All right. So we don't normally see an S wave in AVL. Okay. All right. So, I mean, in leads 1 and AVL. Okay. And then we come to the right side of the heart where we start seeing these QR patterns, which are also abnormal. We don't normally see an R wave in the right side. Okay. So what are we looking at here? Any ideas?
Well, can you hear me?
Yeah, we can hear you, yeah.
Firstly, I would be worried about a PE because of S1, Q3, T3, as well as the P pulmonale. So there could be an element of core pulmonale.
Excellent.
Secondary to P.
Pulmonary embolism. Very good. So that's one of the first things that we would look at. Excellent. Well done, Hedy. Extremely well done. All right. Anything else that we would consider?
And then obviously cardiac ischemia.
Cardiac ischemia, that's also 100% right. Okay. But as you say, a pulmonary embolism is more likely in this patient. All right. So there's a few reasons for that, which we're going to get into now. But so we've got a combination. We've got a query pulmonary embolism, and we've got a query ischemia as well. So any idea what tells us if it's a pulmonary embolism or not? What are the few things that we actually see? Any criteria that you guys know? Besides S1?
Honestly, just the S1, Q3, T3.
All right,
and then
no
the P pulmonale is also.
Yeah, P pulmonale, yeah, that's 100% right. Okay, not a problem. Okay, so this.
Yeah, I'm not sure what else you can say.
No, it's not a problem. Don't stress. You actually did very well. Don't stress. All right. So the good part is that if you were to get this patient, at least you would be investigating for a pulmonary embolism. All right. So, and that's actually where we're heading to in this one as well. And in fact, that's going to be the theme this week, is pulmonary emboli. All right. But let's think about it. All right. Let's look at it logically and see what do we expect to happen. So if you've got an embolus that's lodged in the lung, okay, what do we expect to happen to the right heart? The right side of the heart, which is trying to pump against that embolism. What do we expect it to do? Any idea? So you've got this embolism that's sitting there, all right? It's blocking of blood flow through the lungs, which is the responsibility of the right heart. So this right heart has to try and bypass it. What's the first thing that it will do? Yeah, it's going to enlarge, all right, in the short term to try and overcome it, and try and push past it, all right? So if the right heart enlarges, what do you think will happen to the axis of the? Will it shift or will it stay the same? Which side would it shift to? To the right? No, to the right, yeah, because the right's getting bigger. So it's going to take more electricity. Right? And do we have a right-sided axis here? Yes, we do. All right? So we have a right-sided axis. Okay, what's other things that we expect to happen? So now there's this backlog of blood, all right? So what's going to happen to that right atrium? That's also getting now this backload of blood. What do you think is going to happen? It's going to get bigger or smaller? So this atrium needs to pump into that right ventricle. That right ventricle is getting bigger and it's getting blood that's backed up into it. So what do you think is going to happen to the atrium that needs to push against that thing? It's going to get larger. Very good. So it's going to get larger. So you're going to start to see what you're calling an atrium enlargement as well. Okay. Do you think the heart's going to beat faster or slower? Faster to try and overcome it. All right. Very good. Okay. Now, those are just the logical things behind it. Okay. But there's a lot of criteria that we use to actually decide whether something is a pulmonary embolus or not. But let's have a look at the answer that they give us just so that we can see. So we've got a sinus rhythm, which we kind of figured out. Okay. A rate of 85, which is not really that fast, just a slight tachycardia, but not really that fast. It can be normal for some people, even up to 90, but we say up to 80 is okay. All right. And then they say here T-wave abnormality consistent with anterior and inferior ischemia. So that's 100% right. That's what we were thinking about. And we've got a right with axis. All right. So this ECG is highly suggestive of an acute pulmonary embolism. So well done, Katie. All right. Which this patient did have. All right. So the ECG demonstrates the classic S1, Q3, T3. Now, this is something I always see people talking, they mention it, but they don't actually know what it means. All right. So S1, Q3, T3, basically it means you have a large S wave in lead 1, so S1. You have a Q wave in lead 3, and you have an inverted T wave in lead 3. So hence the name S1, Q3, T3. All right. So that has to do with the changes of the right heart in trying to overcome the blockage that's happening over there. All right. So large S wave in lead 1, small Q wave in lead 3, inverted T wave in lead 3. Present in only 10 to 15% of cases of pulmonary embolism. So can you really rely on it? Nah, not really. It's a good thing to know, and if it happens, then that's very good, This is the more common one. This is the thing that you actually need to consider, and this is the thing that most people actually don't know. So T-wave inversions are common in pulmonary embolism, all right? And the combination of T-wave inversions that occur simultaneously in the inferior and anteroseptal leads should strongly prompt consideration of this diagnosis. So let's go back to that, all right? So when they say inferior, they're talking about leads 2, 3 AVF, V1, V2, V3, V4, all right? So if you were to just look at these, you would think that this is a non-ST elevated MI because of the ST depressions. But actually with the inversion of the T waves, that is almost specific for pulmonary embolism. 95% of the time, if you have this pattern of inverted T waves in the inferior and anteroseptal leads, 95% of the time it turns out to be a pulmonary embolus. So even if you remember nothing else from this lecture, if you just remember inverted T waves in the inferior and anteroseptal leads, is specific for pulmonary embolism 95% of the time. Okay, Petty, you got that? You learned a new criteria now. All right. Okay.
Yeah, well, thank you.
Yeah, it's one that for some reason we all know the classic S1, QT, 3T, right bundle branch blocks, things like that. But for some reason, I don't know why people don't know about this T-wave inversion. So I want you guys to remember that. All right. So right-sided access is often found on ECGs of patients with acute pulmonary embolism or chronic emphysema. All right. So people who've got COPD, so they've got these long-standing pulmonary diseases. These diseases basically cause fibrosis in the lung. They cause vascular, what you call it, constriction. It's more difficult for the heart to actually push against the diseased lung. So they start to get a right-sided, what you call it, dilation as well. So they can also get a right-sided access. Okay. Now, what we're going to look at next is some of the criteria to diagnose a pulmonary embolism. All right. So key ECG findings: tachycardia. All right. Most common abnormality seen in 44% of patients. Well, it's not the most common one. All right, we just but anyway. So tachycardia can occur, but it doesn't always occur. It depends on what's happening to the heart as well. Is there ischemia? Is there previous damage? Things like that, right? Complete or incomplete right bundle branch block, which we saw on our patient as well. So we just go back to that. So that's what the right bundle branch block looks like, all right? So that's where we say that comes from, all right? Right ventricular strain pattern, all right? T-wave inversions in the right precordial leads and inferior leads. This pattern is seen in 34% of patients associated with high pulmonary arterial pressures. Right axis deviation seen in 16% of patients. Extreme right axis may occur with axis between 0 and 90, but anyway, that's not so important. Dominant R wave in V1, okay, which is something that we also saw. Manifestation of acute right ventricular dilatation, right atrium enlargement, P pulmonale, which we saw, peak P waves in V2. And if you can remember that, very good. But the most important thing that you'll see over here, look at the percentages. They're not talking about huge percentages. S1, Q3, T3 pattern, deep S wave, as we mentioned. Classic finding is neither sensitive nor specific, all right, for pulmonary embolism. Okay, and yet it's the one that everybody knows. Okay, clockwise rotation, shift of the right S transition point towards V. If you can remember that, very good. Okay, but I am not very often that you'll actually see that. Right? Atrial tachyarrhythmias, which can happen, but they're not actually that common. And then non-specific T-wave and ST things, all right, that we're saying. But here's the important one. Simultaneous T-wave inversions in leads 2, 3 AVF, right precordial leads V1 and V4 is the most specific finding in favor of PE, with reported specificities of up to 99% in one study. But it depends on history as well. All right. So how do patients with pulmonary embolism present? Any idea? What do you think will happen to them?
Dyspnea, sharp chest pain as an outpatient.
Excellent. Yeah. And then one of the more common ones is syncope as well. All right. So any patient who suddenly drops down, we all get irritated when these patients come. We're like, so you fell down at work. We know you're tired. You don't want to go to work. All right. Can we just write your sick note and send you home now? But the truth is that they may well have a pulmonary embolism. So any patient that faints, do an ECG for them. You never know what could have caused it. All right. So those are the most common physical findings that you'll find. So very good. Now you've done your ECG. You're going to take your bloods, and then on Wednesday, we're going to figure out how you're going to use your ultrasound to confirm your diagnosis, so that by the end of the week, you guys are all masters at picking up pulmonary embolisms, which are some of the most difficult things to pick up. All right, really, they're quite difficult. And even our M&M this month is going to be, I gave it away. All right, but it's going to be about pulmonary embolism. All right, it was supposed to be a surprise. So we're kind of concentrating on that for a few days because it's quite important and quite, it's something that we really need to know about. Now, all of these things, very nice to know, all right? But if you can remember this one, if you forget everything else and you remember that, you'll diagnose pulmonary embolism most of the time. Once you've got a pulmonary embolism, you're also going to look for a source of that embolus. Does the patient have a DVT, which we did in our previous ultrasound lectures, all right? Does the patient have risk factors for pulmonary embolism? Was the patient pregnant? Was the patient on contraceptive? Was the patient seated for a long time? Travel, things like that. So these are all the things that we need to know. Okay, I'm not sure if you guys have any questions or things like that, because these are actually very difficult. The reason why I say that is because if you're not thinking of pulmonary embolus, how are you going to treat this patient? You're going to treat this patient as an ischemia, and you're not even as an acute ischemia, maybe as a non-ST elevated MI. Okay, and if you treat a patient as a non-ST elevated MI, they still require your attention, but not as much attention as a pulmonary embolus. So this is where the problem comes about. And we've had patients admitted like this before. And then the next day, it turns out that they've actually got massive emboli and things like that. And an emboli is going to kill a patient very quickly. An NSTEMI, you can still have a look at it, right? So it's very important to know these things. Okay. So at least, even if you're not 100% sure it's a pulmonary embolus, but at least you'll do your D-dimers, you'll do your clotting profile, and you'll learn how to do an ultrasound to pick it up. And you learn how to look at an X-ray and things like that, which is what we'll go through this month. So I'm not sure if you guys have any questions or anything you want to know. Yeah. Yes, that's 100% right. So what's happening is that the reason why these ones become inverted, like we said, that entire area is becoming larger. So as it becomes larger, and because of the viewpoint, remember each one, V1, V2, V3, V4, whichever one it is, you're all looking at the heart from that particular point of view. Okay. So what actually happens in a pulmonary embolism is that the way that the ventricle repolarizes changes completely. And we're actually going to have a look at that when we have a look at it on Wednesday. And it also has to do with this shift that they were talking about, right? This clockwise rotation of the heart. So with that clockwise rotation of the heart, the point of view that the lead is looking at the heart from, be it from the bottom or be it from the front, actually changes. So whereas before, it would see that electricity of repolarization coming towards it, because there's a change, it now sees that electricity moving away from it. And that's why it's such a common finding, all right? Now, like I say, T waves in themselves are very non-specific. T wave inversions are very non-specific, except in this case, okay? The thing is, in order to understand it, I would advise you guys, if you have done nothing else this week, go and learn the ECG basics. I put those 4 things up, it'll take you like 2 hours, and you'll come back to this and you'll be like, oh, okay, that makes sense now, you know what I mean? The problem is now I can't take you back and teach you those things because each of them is like a half an hour lecture, right? But just to understand this basic thing, when we are looking at each lead is basically looking at the heart from its own particular point of view, okay? And by putting all of those points of view together, that's how you get a full picture of the heart, okay? So this is not a basic ECG. It's actually quite an intense ECG when you really look at it, all right? But in order to make it a bit more, let's say, use a visual metaphor, if I ask Dr. Karwa to describe my face, and I ask you, and I ask you, and I ask you, all of you are going to give similar pictures, but it's not going to be exactly the same. And then ask somebody behind me to describe my face, it's also going to change. The only way that you can get a full view of my face is to put all of those together, which is what we are doing in this ECG, all right? But the only way to get to that point, to understand what's happening here, is to first understand the basics of how we get to that point. I understand your question completely, don't worry. What I'm saying is, you need to understand the basics before you can understand what I'm trying to tell you. I know it seems a bit harsh. I'm not trying to be harsh, I'm just trying to explain. Okay, so T waves, you're 100% right. It has to do with repolarization. So repolarization is when your heart now relaxes. So that produces electrical current as well. And these all have to do with the point of view. So V2 is looking at the heart from a particular point of view, which you'll see in the 4th lecture. And normally, well, actually it does normally see it kind of inverted or flat or whatever it is, but that shouldn't be happening here. So the only reason it happens is because in a pulmonary embolism, this right heart is enlarging, it's causing a shift of the heart. So that's what's causing these inversions. And that's why it's so specific, because it doesn't really happen in many other conditions. It can happen sometimes in COPD that's extreme, you know, real extreme COPD. But even then, too, it's not that common. You'd find other findings. Actually, you'd find more common findings here at the bottom in the rhythm strip as compared to here. All right. I hope that answers something of your question. Okay. All right. Any other questions? Anything else you want to know? Oh, you look like your brain is buzzing. Got 10 million questions. Katie, do you have any questions? You always have questions. But I know you haven't been on call recently because you haven't been asking questions after hours.
No, it's okay. I'm good, thanks.
All right, no problem. It makes sense. These are difficult ECGs, and the truth be told, even looking at that, you can't say 100% for sure about a pulmonary embolism. The most important thing to understand from this, it needs to be one of your differential diagnoses. Then there's other tools that you would use, such as your ultrasound, X-ray, blood work, and history to say that, listen, it is more likely a pulmonary embolus. Yes, somebody's got their hand raised. By all means, you can either talk or...
Dr. Yusuf.
Hi.
Morning. I want to know, in pulmonary embolism,
Yes.
do you also get extreme axis deviation?
Yes, you're 100%.
Always associated with right axis deviation?
No, it depends on the acuity of the embolism. All right. So what happens is, if you catch it in the extremely early phase, you may only get a right-sided, and it also depends on the size of the embolism as well. So if you have microemboli, you may not end up having a extreme right axis deviation. However, if you have a massive embolus, your heart will very quickly go to an extreme right axis. And to be dead honest, the reason why I chose this one, there's much more typical examples of pulmonary embolism out there. But I wanted you guys to actually have a look at where it can be easy to trip up, all right? And right axis deviation is actually not as common as extreme right axis deviation. You're 100% right, but you can find both of them. But it depends on the acuity, it depends on the size of the embolus, and it depends on the rotation of the heart as well, all right? So there's quite a few. The most important thing to remember is that to make an ECG diagnosis of pulmonary embolism is very short-sighted, okay? It's kind of like making a diagnosis of pneumonia without listening to the chest or by just looking at an X-ray. You get what I'm saying? It should start guiding you to say that, listen, there is evidence of pulmonary embolism. Now I'm going to do other things. Okay, but these criteria that I've mentioned should at least get you thinking. This could be a pulmonary embolism. I hope that answers the question, Doc. A little bit.
Thank you.
Okay, no problem. Okay, I'm not sure if anybody else has any other questions or if everybody's happy. And like I say, on Wednesday, what we're going to do is that we're going to, we will now go through the, what am I trying to do here? Sorry. We will try to go through the ultrasound findings on a pulmonary embolism, all right, to try and see what we can find. And then I would advise, if you haven't had a look at the DVT ultrasound, go and have a look at that, because that forms a big part of pulmonary embolism workup, all right, to figure out how you actually look at a DVT, to try and figure out if the patient does have a DVT, because these are things that you do whenever we have a pulmonary embolism. Chances are today, because it's Murphy's Law, whenever we seem to talk about a topic, we always tend to get one of those patients, so keep an eye out, right? I mean, last week, what did we spoke about ear injuries, and the very next day we had a typical ear injury that came in. Dr. Hedi was actually suturing it up, you know, and I got very happy. I thought he watched my lecture, but it turned out he learned it as an intern. So, you know, I can't take credit for that, but he did a wonderful job on it with the intern. And Hedi, that poor intern, only left at 9:30. So, you know, you really screwed him over, eh? All right. So listen, if everybody's okay, we will end over there. And if you have any more questions, by all means, you can always message on the chat, and I'll post the video a bit later. Okay. All right. Bye-bye, everybody. We'll see you all on Wednesday. Okay.